the baby's risk, a higher risk of dying before their 5th birthday. So again, you can see where we need to concentrate our efforts worldwide. And I have to say, having just moved to Mississippi in the US, we need to concentrate our efforts in the South. We're not doing so well there either. So again, when you look at the worldwide causes of neonatal death, preterm birth, severe infections, and asphyxia cover the vast majority, and we can do something about all of these areas. So we know when babies are first born, number one, in sub-Saharan Africa and Southern Asia, the vast majority are born at home, away from physicians or actual midwives. Many of them have only birth attendants or their neighbor to help assist in the delivery. But thankfully, for most babies at birth, they just need assessment and routine care, so 80 to 90% worldwide. Some babies need a little bit extra: drying, warmth, clearing the airway, and stimulation. These are things that can be easily taught but are not typically done. And then another subset, about 3 to 6%, need bag and mask ventilation to make that first breath effective or to implement that first breath. And very few actually need the complicated resuscitation that we do in the United States with chest compressions and medications. But the challenges of teaching all of this in resource-poor developing countries are that there are limited medical facilities for deliveries. There are very few people that are trained who attend births. The skill level and literacy of those providing care is very low. Oh, this one's working out, okay. That we need to maintain the skills, so it's not enough just to parachute in, teach people how to do this, and then leave and think they're going to retain those skills. We need a supply chain for the equipment and how to resupply. We need a way to collect the data to make sure we know that we're doing a good job and that we're effective. Quality improvement and assessment. And then we have a lot of cultural awareness and differences that we need to overcome. Do they have certain things like putting cow dung on the umbilical cord that we need to interact with in that local area to make sure that doesn't happen? There's a lot of inefficiencies in the government, and then the own governmental self-perception of the medical system. They really don't love it when people from the United States say you're doing terrible and this is what you need to do. They often want us to do the high-tech things, and that's not where we need to focus. Having said all that, we've been very successful in the AAP neonatal resuscitation program, developed by AAP, evidence-based, has been used for 30 years, especially in the developed world, used in high-resource settings, and it really teaches those first initial steps of resuscitation. But we felt and we realized this was not going to be very effective in the rest of the world where the majority of neonatal mortality was occurring. So we needed to develop something in limited resource, so a global development alliance combined. Unfortunately, we are pretty well funded with AAP, USAID, NICHD, Save the Children, Laerdal, and then support from the Latter-day Saints. So we do have pretty good funding to implement this around the world. And so this is a suite of teaching modules, but it's a whole program. It's a whole country program, helping babies breathe, so to assess and implement and interact with people that are having that initial first problem with breathing, essential care for every baby, so really teaching about the first day and the first week of life to interact and implement change. And then to a module we're just developing right now is essential care for small babies, to really get those late preterm babies and how to deal with them and deliver medical care to save their lives. So again, this is an example of a baby born in sub-Saharan Africa, not breathing. Baby eventually died because people there at the delivery just did not know how to do simple things to start that first breath. So again, for helping babies breathe, to make sure that babies have a skilled birth attendant in every delivery so we can reduce mortality due to asphyxia, we need to go into the countries and collaborate. It really does not work just to go and teach without setting up that infrastructure because it cannot be maintained. We're realizing this and we're doing that on a global level, but we're really focusing in a few countries, and I'll tell you more about that. It needs to be country owned and led. We might have the skill to teach, but they need to carry that on. Integrating with maternal and essential newborn care, so what they do in that country already. And we want to make sure that everything can be used worldwide, so everything is available on the HBB website from the AAP. So the concept is it's pictorial, so even if you can't read, you can teach it to somebody, limited text, hands-on performance, frequent skills practice, the simplest steps possible, and for HBB, teaching the golden minute. That first minute is crucial. So again, here are people that are learning. So we have gone to other countries, in-country taught people how to do these skills. You can see the flip chart that's used for the teaching. They're very simple mannequins that are not super expensive by US cost, but maybe expensive throughout the world. Again, they all have an action plan, so pictorial, showing all the learners what they might encounter and going down an algorithm, what they need to do in each step. So again, very easy to understand. Again, routine care, just clearing the airway, drying, keeping the baby warm, cutting the cord, encouraging breastfeeding, teaching all these steps in a very systematic fashion and making sure that people understand and can practice this. Then the golden minute for if a baby is not crying or breathing, how to clear the airway, stimulate, and initiating ventilation with a very simple bag mask bulb syringe system. Again, really, is the baby blue and not crying, not breathing? How can we convert that baby to a baby that's breathing? There are learner workbooks that are with this entire module that the learners take home and use to practice, again with pictures, teaching each other, so this paired methodology of education is very important. They do exercises so they can reinforce their skills, and then using a very easy simulator that mimics a baby that can just be filled with water and is very tough and can last for a long time. Again, doing pair learning and teaching, and it can be taught all over the world, and these materials are adapted in many, many languages. And it's sustainable, it's low cost, it's effective, it's easy to integrate into the current health system. Again, some studies have come out. It is effective. It's decreased neonatal mortality. It's decreased stillbirths, which used to be babies that didn't breathe, so they were all counted as dead. So again, toolkit has the action plan, the workbooks, the flip charts, practicing, simulator that's included in the kit, and then very simple materials that people can use to resuscitate. I'm just going to mention the last two modules, the essential care for every baby. So again, taking that first resuscitation and expanding it to the first day. What do people at the bedside or in the home need to do to keep that baby healthy for that first week? Initiating breastfeeding, cord care, skin to skin, temperature control, giving vitamin K, and knowing when a baby's sick. And then finally, we are now just rolling out this final module, essential care for the small baby. So using that same methodology to teach and treat the late preterm to allow that baby that's 34, 33, 35 weeks to survive in countries where they might not survive now, but with some simple techniques can survive and live a very long time to show up for the acute care in the ER that you all are teaching about. So again, we're going to be doing that course in July. So thank you very much for your attention.
Thank you.